thick skin patient, I think there is a if uh, I think not so useful in the supratip break concept, but in your patient, I think in the Singapore the patient are not the thick skin patient, so I think it's okay.
Yeah, I think
Just a minute.
it's not only about creating the suppurative break, but
Yeah.
also to prevent um, soft tissue polypeak later on. Sometimes because of bunching in the
Yeah.
tip area, you can get that if you don't reconstruct this structure later on.
Yeah.
I think it helps from that point of view.
Yeah, perfect. So basically, it's a one of a minor tip support mechanism also. Then later we discuss regarding the tip. So after the exposure of the both of the lateral crust, then we deglowing this mid vault like this. You can use the seizure. You can. I usually use this Kakir periosteum elevator, and you just hug with your this mid vault, and then you expose the your bony vault. Now, again, the question that what is your upper limit of the dissection, that is the intercanthal line, and on either side, at least you should expose around the 1 centimeter on either side, because definitely when you have a crooked nose, then you complete exposure of your inner framework just for modification is important. So now we expose the lower lateral cartilage, then the mid vault upper lateral, and the bony pyramid. So now we further move for the septum exposure. I usually use this basically it's a self-retaining dorsal retractor, the very good instrument of the Najim circus, developed by the Najim circus, self-retaining. So no need to hold this. Okay, otherwise one person may hold this by this off-ridge retractor. So now the further step, because now we want to expose your septum. So what is your further step? You need the two these Takahashi these forceps. Okay, so you hold ऐसी forceps नहीं हो. हाँ. So like this, you just give the counter tractions first. Okay, just on the anterior inferior directions, and then you need the sharp seizure, and then spread it and cut it like this is the interdermal ligament. Okay, just it, cut it. मेरी headlight की battery change करना, and again you spread it and cut it. But in your eyes, in your mind, you have a framing that what you want to identify. We want to identify the anterior septal angle area. Okay, so just spread it and little bit. Automatically, you find something. Look there, this is your septum. Okay, this is your septum. So now you change how you hold like this. यहीं रहो यहाँ पे. You hold like this. Ask your assistant इधर से पकड़ो. Because earlier we hold like this. Now we hold like this, just nearer to this one. Now the things are changed. So everything is important. Again, we separate this little bit and spread it and cut it. So we expose our septum. Now for expose of your mucopericondium, deglowing your mucopericondium. Now I usually use this seizure just as a pen holding position. You can use the
Please ask this cameraman to focus the light. Actually, too much of light is there on that.
अच्छा
Glare is there, glare.
देखना, चेंज करो थोड़ा सा. आप थोड़ा सा इसको जूम बढ़ाओ आप दीपक जी, आप पास में लो एक बार. बस अभी कैसे हैं?
अभी से center out हो गया थोड़ा. Now it's okay. Okay, all right.
So you hold this seizure just as a pen holding positions, and then just you separate this mucopericondium like this, and remember then this is the one of the most difficult step in the rhinoplasty, especially when you have sometimes a beginner and when you have sometimes a crooked nose, when you have a post-septoplastic cases or in a pediatric rhinoplasty cases. So if you find to get the plane on one side, then you never panic. If you sometimes you have a injury in the mucoperichondrium, so you change your directions, you go on another side, because in the rhinoplasty, uh, just to keep the patience is important. But another important thing, if you hold like from this and if you do work, that the things are different. But if you hold from the near one, look that you develop the things, you develop a net. So this net that is good for you. So you just separate this mucoperichondrium, just like you can use the periostem elevator also. And if you are in the wrong plane, then you just keep the patience and just to make a scratch by end of the 15 number blades, and then you can. But if you are in the wrong plane, then you have a lot of bleeding. Wherever you have a bleeding, then something is going on the wrong. Okay. Then on another side, छोड़ो इसको. Again, I
Dr.
like
Sandeep.
this. Just you hold. Now this is the same.
Dr. Sandeep has joined.
Hello.
Sir, good afternoon.
Good afternoon.
Hi, good morning. Sorry.
We are waiting for you.
My apologies. I had a very late night last night, so I apologize. It's early in the morning here, and I did put my alarm on, and I slept right through it.
Okay. Good. Thank you, sir, and welcome, sir.
How are you?
Morning, everyone. Dr. Sandeep, good morning. I'm Dr. Goel.
Hi, good morning. How are you, Doctor?
I'm good. I just want to have a comment.
Yes.
For pericondial dissection, I use 15 number of blade.
Yeah.
And the back side of that.
Yeah.
So that's
15 number
again
then.
very good
15 number.
thing. You don't injure anything, and it is.
Yeah, you use like, sir. Yeah, like this.
Yes,
Yeah.
yes. That's
That
right.
also learn the technique also. But I just make this easy the things for our participants. So that's why I use. Otherwise, once you develop the habit, then you can use either the 15 number, you can use the seizure, and you can use. So now there is, you follow a certain sequence when you deglowing your mucoperichondium. You know, first you deglowing on the anterior superior part, and then you just on the posterior inferior part, and then the posterior superior, and in the last on the anterior inferior. Why? Because on the anterior inferior we have the densely mucoperiosteal attachment. So if you develop the sequential your work, then you have the less complications. Give me the periostem elevator. And another important thing on this stage, now for my beginner friend, then for getting the more exposure, I think is better you just separate the upper lateral and the septum. But before to separate the upper lateral and the septum, you just assure your mucoperichondium internal nasal wall area, you deglowing it completely. Look that you can appreciate, you can appreciate my periostem elevator. So you first deglowing this mucoperichondium in this internal nasal wall area before to separate the periostem, separate the upper lateral and the septum. So like in this way, on this side also, you can appreciate my periostem elevator. Okay. Now you separate the upper lateral and the septum for getting the more exposure. So this is my right side of the upper lateral. Now I separate it like this and like this. But if you separate it without separating this mucoperichondium, you have a lot of the bleed, and later you develop the synechia in this area, and consequently you develop the functional problem. So I separate. Now you have a lot of space just for work, for exposure. Okay. Give me the periostem elevator. I usually use this storage periostem elevator, that the one side is sharp and another side little bit blunt. इसको पकड़ो मुकेश, इसको पकड़ो. And you can use this self-retaining lateral crura retractor like this. So you have a, everything is under your exposure. Okay. Now you separate this mucopericordium is so simple. First, just in the posterior inferior, and everything is in front of your vision. And once you separate on the both sides, look at, then on the posterior superior region. Now on this side, septum work is the key step in the rhinoplasty. This patient on this side have some infection, cadaver have the some abscess or something on the, so just I follow the same sequence on this side also. So I complete separate, and now on anteriorly on this part also. Yes. In this inferior part of the caudal septum. This have this infection. Yes. So now this step, the exposure is complete. We expose the lower lateral cartilage, we expose the mid-wall upper lateral cartilage, and we expose the bony pyramid. Okay. So we just discuss little bit the interior anatomy and the internal relationship. Then we follow the next step. Look that this is the septum. Okay. Because the septum just have the three part. One is the bony septum, that is the cartilaginous septum, and just behind this medial crest we have the membranous septum. Okay, this septum, this superior border, that is the dorsal part of the septum. This is the caudal part of the septum. Okay, double look laga na bada. So the angle between this dorsal and caudal part, this is the anterior septal angle area. Okay, we have the two more septal angle also, but clinically this anterior septal angle is important. Another, the angle between this posterior part of the septum and this caudal part of the septum, this is the posterior septal angle area, and this is the mid septal angle area. Okay, now this is the right side of the upper lateral, this is the left side of the upper lateral. Okay, and this upper lateral, ऐसे करना है इसको, this upper lateral is a basically just the T-sept cartilage. Okay, that have the medially, this is the medial margin of this upper lateral, and one is the lateral margin of the upper lateral. Okay, they both end of the medial and the lateral end is important. Medial end of this upper lateral cartilage, they attach with the septum at a specific 10 to 50 degree angle, that we say the internal nasal wall area. Okay, and the lateral most part of this upper lateral, this doesn't have any sound attachment. This attaches only a wedge of a triangular bone in the lower part of the piriform aperture, that we call the Webster triangle area. Okay, and one is the superior end, one is the inferior end of this upper lateral cartilage. So the superior end of this upper lateral, this is the, this superior end of the upper lateral cartilage that attached with the distal part of the nasal bone, that is the keystone area, that is the keystone area. So in this center part, the overlapping of this distal part of the nasal bone and this proximal part of the upper lateral cartilage is maximum, that is around 9 mm. But if you go on the lateral, in the peripheral keystone area, that is overlapping is reduced. So this upper lateral cartilage get maximum support from this central keystone area. That's why we always maintain integrity of this area of the keystone, central keystone area. Okay, and if you come on the lower down, थोड़ा सा straight come करो, If you come on the lower down, then double forceps do. The lower end of this upper lateral cartilage, the lower end of this upper lateral cartilage, marker bhi dena, and the upper part of this lateral crust, they have a overlapping. What is the name of that one? Scroll area. That is the scroll area. The scroll area that overlapping around the 15 mm. This one. So this is the scroll area. What is the significance of the scroll area? This is the scroll area, because it is a one of a major tip support mechanism, because the tip have the three important tip support mechanism. One is the size, shape, and resilience. This is the resilience. This is the resilience of the entire Alar cartilage. Second, that is the scroll area, and third is the attachment of the caudal part of the septum with medial crust. So tip have these three major tip support mechanism. So this is the scroll area. This is the scroll area. We always preserve the scroll area. Okay. Now, if we come the anatomy of this after the septum and this upper lateral cartilage, this is the a pair of Alar cartilage. Okay. So this one pair of Alar cartilage, this forms a tripod. Okay. This is the central limb of the tripod, and this is the lateral limb of the tripod. Okay. So this Alar cartilage, have the three part. You visible the three part? One is the medial most part, this one. One is the lateral most part, this one. And the part connecting these lateral most and the medial most part, this one. So this is the medial crust, this is the lateral crust, and the part connect, that is the intermediate crust or the middle crust. Each part have their own significance, and we deal according to the present anatomical deformities. Okay. This first part, medial most part, that is the medial crust. This medial crust is basically a principal component of this columella. Okay. And this is responsible for the mainly the projection of the tip. And this have the two part. One is the foot plate part. This part is the foot plate part. This part is the foot plate part. Okay. And this part is the columella part. This foot plate is basically rest on the anterior nasal spine. We have a fatty tissue here. Sometimes after the infections or injury or after the surgery, if the fatty tissue may get reabsorbed, the patient develop the droopy. And we never disturb this foot plate part, because or incision, that's why we always keep above, because we have a major tip support mechanism. Okay. And then the second part, that is the intermediate crust. Again, the intermediate crust have the two part. This angled part, that is the dome part, anterior part, that is the dome part, and this is the lobular part, where the medial crust start to diverge, where we start the lobular part. So this lobular part is basically responsible for the infratip lobule. Okay. And this part, dome part, that is basically for the width of the tip and the definition of the tip. It's very important part. This is the smallest part of the Alar cartilage, but is mainly responsible for the angle and the shape and width of the tip. Okay. And then the third part, this is the lateral crust. This is the widest part of the Alar cartilage. Okay. And this part is maximal responsible for giving the volume of the tip. Okay. And these have the two margin. This is the cephalic margin that we already discussed, that form the scroll area, and the caudal margin of this lateral crest is also important, because this caudal part is responsible. Basically, we usually use as a landmark for the marginal incision, for the infiltration. Okay. And this caudal margin of the lateral crest, that also give the support anterior half of the basically this alar margin. Okay. So this all about the anatomy of this upper lateral, lower lateral, and the septum. But there is certain interrelationship of this anatomy. There is a relationship between this dome and this anterior septal angle. Okay. Ideally, the dome, this dome area, that is around the 5 mm anterior and 1 centimeter caudal to this anterior septal angle. That's why we usually have a supratip break, because this dome area is little bit higher and anterior. That's why we have the supratip break. Another important relation, the relation between this caudal part of the septum and between this medial crust. Ideally, around the 2 to 4 mm protruding this caudal part of the septum between this medial crust. Okay, for a normal columella show. What is the columella show? Uh, you know, uh, the the one is the normal columella show. What is the normal columella show? Ideally, there is a relationship between the ala margin and this columella. Around the columella is a 4 mm. This part is the 4 mm anterior. Why? Because this caudal part of the septum that around the 2 mm between this medial crust. If more than this, then we have a hanging columella. Less than this, we have the retracted columella. Okay, so these are the relationship between interrelationship, and the distance between this dome area, that is also fixed, that is around the 6 to 8 mm in the female patient, but 8 to 10 mm in a male patient. So you have to know about the normal anatomy, about the normal relationship between these area. So now we complete or the exposure part. Now we move or third G step, third golden step of open rhinoplasty, that is the septum modifications. So in septum modification, first you go like initially and the time of the start we dissection that I mentioned, what is the concern of your patient. If your concern of the patient is purely cosmetic, no functional problem, then just you harvest the septal cartilage. Okay, but if your patient concern is functional, then for functional correction we just go either the septoplasty, either the septal reconstruction, either the septum repositions. We all things are similar. So before to modification of the septum, first you analyze your septum. If you think your patient have the functional problem, okay, then before to create the L strut, first if your septum have axis dorsal part, वो लगा ना self retaining. If your dorsum you have the axis dorsal part or axis caudal part, you trim it. But the usual common mistake by my beginner friends, they first the harvest the septal cartilage, they create the L strut, and after they trim the axis part, then they weak their L strut. Okay, so first you analyze. Suppose in this patient 15 number blade, then suppose in this patient, look, we have this axis part, because this patient have a caudal, this cadaver have a caudal septum deviation, so we have this axis part. So वो लगाना यहाँ पे, we first excise the axis part. So we excise this axis part of the septum. Because when we excise this axis part of the septum, that they allow the come to in the midline. And if you suppose if you have the axis part of this one, then you just excise, like you hold like this and then in this manner. Okay, so first you judge that whatever amount you have the axis, you excise like this. Now you create your preserve your L strut. So this is your septal cartilage, and you for create the L strut marker dena. First you preserve at least 1.5 centimeter dorsal and 1.5 centimeter anterior. Like you mark like this, and then note the acute angle like this. Okay, and then you just use the scissor, your knife, just you hold this one, like you appreciate it. So now just you make an incision here, yes, and then just you rotate it, then not the acute angle. So now we separate from the superiorly and from the anterior part of the septum, and now just you need this speculum Sandeep sir, you want to add something regarding the AL strut? Sandeep sir?
Yeah, I'm here. No, I think it's every year I watch you do this, and every year it just it's great. Everything I've ever taught you seems to be you're being teaching everyone else. So no, that's great. Yeah, I mean, I'd agree that the one thing you've got to be careful about though when you're leaving the L strut is making sure that you judge, because if you've got a big hump
Yeah.
and you leave 1 centimeter and then you're taking away 3 to 4 millimeters, then you're going to end up with inadequate support there. So you must make sure that you leave enough cartilage. And if you're not sure, do all the dehumping first and then take the cartilage you need for grafting afterwards. So often I will leave this till a bit later on in the dissection if you're not sure how much you're going to remove from, because you want to make sure that you leave enough support in the L strut, because that's the problem. And like you said, beginners will sometimes take away too much to begin with and then find that they're stuck then, because if they're having to remove quite a lot of cartilage at the dorsum, and then they've not left enough behind. But other than that, no, I'd agree with everything you're saying.
Yes, sir. Perfect. So first you just judge, and like sir says, first you judge according to your case. If you have axis, then you excise the axis bump, and then now I separate the this part of the septum from superiorly, anteriorly. Now from the posteriorly, I usually use this sharp instrument. Just some people use a Bellinger knife also, but I by this multiple perforations, like I separate from the PP, perpendicular plate of the ethmoid. You can appreciate it. Look at, and then you like this. Then first you check either you separate or not completely cartilage holding forceps. So first you check if you feel that little bit attachment, still you never pull it. If you pull it, then entire septum is come out. Okay, then you 15 number bleed, 15 number bleed. So just we cut it a little bit, and then again we remove this one. Yes, sir.
How do we cut the bony septum?
But usually I use this sharp instrument. Look at just I separate from the attachment from the perpendicular plate by the multiple perforation, just like this, and you can use like the Bellinger knife also. So this is the way. Then I usually separate from the bony septum this septal cartilage. And
Don't you want?
I think Dr. Kapil was asking about actually taking out bony septum. If you need to take out bony septum itself,
yes.
How would you do that, Sunil? How would you do that?
Yeah, so first I just remove this my septal cartilage, and then if my bony part of the septum is deviated, okay, and then the two things. First thing, if there is a small deviations, then I fracture it and medialize it. And if on the other hand, if you have a gross bony spur, then I remove that spur. So then give me the lux forceps. So then you expose your both sides, degloving your mucopericardium, and then if you have a bony spur, then you just rotate it. But after the rotation, you again rotate in the midline and then you remove it. But if you not rotate it in the midline, then you damage your mucopericardia. You develop the septal perforations. So this is the way then you can deal. But it's depend. Then it's not, because this is a common question beginner by friends. Then is there necessary to remove the bony part of the septum also? So it's depend what your patient have a anatomical deformity. If only the deviation, you fracture it and is allow in the midline. And but obviously if you have a bump, if you have a spur, then you remove it.
I think Dr. Kapil may be asking because if you want to use a bony graft as well. So yes, you're right in terms of you may not need to remove it for functional purposes, but if sometimes you want to use a perpendicular plate of the ethmoid graft, or sometimes you want to keep the attached, so you get a composite type graft, so you leave the bone attached to the cartilage, then I will tend to use a turbinectomy scissor to cut at the top end. The most important, the most important thing is for anyone out there is not just to twist the bone in the perpendicular plate to the ethmoid, because it can be attached right up onto the skull base area, and if you just twist without cutting, you do risk CSF leaks. So I think you always cut. We're using whatever instrument. Some people use piezo. I tend to use a turbinectomy scissor just right up at the skull base area, and that way you've created a controlled fracture effectively in that region, and then you can remove the bone by just gently mobilizing what's left of the bone underneath, and then you can get a composite bony cartilaginous graft, or you can just take a bone graft out alone if you want to just take the cartilage and the bone separately. But I think that's what you're asking. Is that right, Dr. Kapil?
Yes. You explained very well, and it actually serves both the purposes. You can get the graft as well as any deviation or something is there, it comes out.
Yes,
without,
you are perfect.
and it will not create any cribriform fracture, so there won't be any leak.
Yeah, I mean, there's a lot of controversy whether you need to remove posterior bony spurs, because of course most blockage occurs in the caudal aspect of the nose, not posteriorly. So whether or not removing a bony spur makes any difference to the function is controversial. But having said that, when as we all have done, particularly those of us who are ENT trained, you do a septoplasty and you leave a bony bit behind, and then the patient comes back with blockage, then you're always questioning, should I have removed a bit of bone at the back, and is that why they're blocked? So I tend to remove it anyway, just to make me feel better, if not necessarily there's good evidence that it makes any difference.
Yes, sir. So now after that,
Dr. Sunil, I will take your leave for just for half an hour. I have to attend one meeting and will come back soon.
yeah, it's okay, boss. Okay.
Thank you very much.
So now after the harvesting the septal cartilage, this is our ALST. This is the dorsal part of the ALST. This is the caudal part of the ALST. So look that this is the anterior septal angle. This is the posterior septal angle. So this is the part of the septum that is the deviated, because itself the deviated part that affect the push effect on the septum. Okay. So we axis part of the septum we remove. Give me the scissor dena. So this is the axis part of the septum. Now look that the septum is midline. Look that we remove the axis part of the septum. Okay. So now for the reconstruction of the septum, suppose this caudal part of the septum is earlier like this. This caudal part of the septum is deviated on the one side. If your caudal part of the septum is already in the midline at the anterior nasal spine, there is no need to do anything. But if your caudal part of the septum is deviated, then you, after complete removal axis part, then again you refix it. You reposition in the midline for 0PDS. So there are the different method to fixation of this caudal part. Mostly people use a Linderman burr just to make a hole in the anterior nasal spine, but that is too difficult for my beginner friends. And because in Caucasian patient we have a big long antenasal spine, then easy to make the hole. But in our Asian patient we have very small anterior this nasal spine. So this is a very good methods that I learned from my mentor, Dr. Sandeep Paun. That is a very easy methods for my beginners just to fix. You can fix it like with the mucoperiosteums by this 4-OPDS suture. I usually use the 4-OPDS suture. So I pass it from the mucoperiosteum from the one side, and then again from this like this. So this is the simple method, because we just fix it with the anterior nasal spine mucoperiosteum.
Dear Sunil.
Yes, Dr. Hakim, how are you?
I'm fine, thank you. My greeting to all, especially our teachers monitoring this session. Dear, when you suture the posterior caudal angle to the spine,
Yeah.
will you put the septum straight on the level of the spine? All the caudal part, you make it little bit anterior to the spine, 1 or 2 millimeter.
Not too much anterior, exact on the anterior nasal spine. Not too much anterior.
Because normally, I think it is little bit anterior to the spine. Am I right, Dr. Santip?
Yes, it probably is true. That's probably true that the caudal border just sits, or it's not actually the caudal border. The posterior septal angle, by definition,
Yes.
it's
Yeah.
in the anterior nasal spine. But there is a little portion that comes more anterior to it. So when you're actually attaching, I mean, there's two things about that attachment. One, which Sunil showed, you put it through the periosteum, but Sunil, you should show that maneuver where I picked the skull up, pick the whole head up using that stitch, because the most important thing is that stitch is onto the periosteum. It's very easy to put it just
Yes,
through
yes,
soft
yes.
tissue,
This
right?
is
And
strong.
not.
Look that.
So if you see
Very
this, it
strong.
needs to be literally. You need to be able to lift the
And
skull
move that
up
skull. Look that.
using that stitch.
So it's a
Yeah.
strong attachment.
Yeah, it has to be a strong attachment. In other words, it has to be through mucoperiosteum. So if you look at the current, Hakeem, if you look at where Sunil has done his, there's a little portion there that's sitting forward, a millimeter or two forward, like you said. But actually what it is that's the part of the caudal septum that's coming forward in front of the anterior nasal spine. But the actual posterior septal angle sits in the anterior nasal spine. And then there's a little bit which comes forward a millimeter or two in front of it. So that's the bit I think you're thinking about. So you don't necessarily attach it more anterior. It will automatically come a little bit more anterior if you put it in the correct place. Now, sometimes you don't want that. Sometimes you want to push the cartilage back or pull the cartilage forward even. You can even pull the cartilage forward if you want to do like a tonguing groove, but you've got too far, cartilage is too far back. You can do lots of different things. But as a general rule, you put the posterior septal angle into the anterior nasal spine, and then there is a little bit that sits forward to that. I hope that's clear.
Yeah, exactly, sir. So
Yeah, so clear. So clear. Thank you.
So we just complete our septum modifications, because sometimes if your patient maybe have some dorsal part of the deviation of the septum, then we reconstruct this dorsal part of the L strut also. But I usually reconstruct it later. First, I move my bony pyramid modification if my patient, because that is the little bit crude work, and then after the first, I complete my bony pyramid modification, then I come down my mid vault modification, mid vault work, and then I come down to the tip work. So then we move for this bony pyramid modifications. So give me the seizure. I just separate. So bony pyramid modifications, usually we have the different type of the other methods like osteotomy, यहाँ से पकड़ो, like osteoplasty, but most commonly we usually use that is the osteotomy. And really in the rhinoplasty, there is a two basically procedure that is little bit confusing and too difficult. One is the osteotomy, and that another is the Alar base excision. We a little bit biased about that the patient need or not. So we have to need the comprehensive knowledge of the regarding indications, anatomy, all of these things. So we separate the skin. This is the cadaver, not in the live patient. So we just one side we expose more. यहाँ से पकड़ो. So first we know exactly that what is the osteotomies. So by the definition, osteotomy is really the control factor of this nasal bone just for the desirable width of this bony vault. Okay, and for the getting the desirable dorsal aesthetic line. And really in this osteotomy also we have the challenging factor. Why? Because while we are performing this osteotomy, that we cannot see, we just feel it. And another problem on that, the thickness of nasal bone. The thickness of nasal bone on this same patient, from the top, from the mid, from the down, that is the different. So there is lot of variation in the length. So that's why this osteotomy is one of the most difficult and least controllable step in the rhinoplasty. Okay, so for actually you need the complete morphology of the bony nasal vault. Either your patient need or not osteotomy, you know about the different type and indication of the osteotomy, and you know about the sequence and the pattern of the osteotomy, and you have which osteotomy you need. And also you have the knowledge regarding the surface landmark also, what is the surface marking. So first we learn regarding the morphology of this bony nasal vault. So in morphology, first you look that, you give me the sharp scissor on periostem elevator. First, you learn the different component of this bony nasal vault. This entire bony nasal vault that is consist by a pair of nasal bone and ascending process of the maxilla. Basically, these have the 6 important attachment: superior, superolaterally the lacrimal, and then anterolateral, that is the ascending process of the maxilla. Superiorly, we have the nasal process of frontal process of the nasal bone, and inferiorly, we have this upper lateral cartilage. And on underside, top to bottom, we have the bony septum. So, regarding the size and shape of this entire nasal bone, if you compare the size of this, then the size of this nasal bone in nasofrontal suture area, this is nasofrontal suture area, this is the widest, around the 14 mm. But if you come down, then it's gradually narrow, and then again it widen. So the size variation in the size of this nasal bone is responsible for this hourglass shape of this bony vault. That's why we get on the dorsal aesthetic line. Okay, so why we get the dorsal aesthetic line? Because there is variation in the size. This is around the 14 mm, you come to 10 to 12, and around the 10, and then 10 to 12 in this area. So that is responsible for dorsal aesthetic line. So what exact significance of the dorsal aesthetic line? Because the dorsal aesthetic line, they depict the contour irregularities. If you have a excessive curving, that indicate either the over wide bony vault or the pinching of the mid vault. Okay, and then the length and the thickness of the nasal bone is the different. Ideally, the length of this nasal bone, that is around the 2.5 centimeter, but the thickness of the nasal bone, that is also very from the lower part also. The lateral nasal was, the thickness is also in the mid part of this lateral nasal was, that has the highest the thickness. Sometimes, some patient basically have very short nasal bone, very short nasal bone. Then if you do the osteotomy, in that case, you have a lot of chance of the fragmentation of this nasal bone. So, and in that case, what happened? This upper lateral cartilage have lost the support, and this inferiormedially collapse. So ultimately, the patient develop the inverted V deformity. What is the inverted V deformity? Then this upper lateral is the inferiormedially collapse when a patient have a very short nasal bone. This is the inverted V deformity. Okay, and sometimes when you have a bump, lot of bump, more than 5 mm, and when you excise the bump, then there is a space created between the nasal bone and the septum, that is the open roof deformity. Okay, and another thing, that is the width of this nasal bone is also, because the width, there is a 2 types of the width of this nasal bone. One is the bony base width. What is the bony base width? That is the distance between both sides of the ascending process of the maxilla. One is the dorsal width, the width between this nasal bone. Okay, marker dena. So sometimes if your pathway of the osteotomy is higher and your patient have a excessive bony base width, then what happened? That part is just feel like a step. That is a stair step deformity. Okay. So look that this is the junction of the, yeah, this is the ascending process of the maxilla, and this is my nasal bone. Okay, and this is the pyriform aperture. This is the pyriform aperture.
Sunil, can you just show from the side view?
Yeah, अरे उसको बुलाना कैमरे वाले को. Definitely show boss. उसको बुलाओ कैमरे वाले को, उसको बोलो यहाँ से दिखाना ये lateral side view. यहाँ से दिखाना, वो कहाँ है, थोड़ा सा इधर करो. So basically after the morphology, in the morphology we just learn the different width, length, thickness, size, shape of this nasal bone, and then you also know about the different type, the knowledge of the osteotome also. There is a two type of the osteotome then usually use. One is the straight osteotome, another is the curved osteotome, or one is the guarding and one is the without guarding osteotomes. Okay, so when you use a straight osteotome, then definitely you have the less injury of the your periosteum, you have the less edema. But when you use the guarding osteotome, then you osteotome dena later. When you use the guarding osteotome, then this part throughout the osteotomy you can feel this part. It is that part is easy to where you are working. But on the other hand, this part damage the periosteal attachment. So the literature says that when you have the more edema later. But whatever you use, either the straight or either the this guarded, the patient deformity that should be correct, and it's a hardly matter, I think, in my opinion. Dr. Sandeep, what you suggest that regarding the guarding and the straight osteotome regarding the post-op later edema or bruising?
I don't see much difference. The only thing is it depends on the osteotome itself. I mean, some of those guards are very, very wide. So if you look at when you buy an osteotome, a lateral osteotome, if you're going to use that, then make sure that the guard is very, very thin, and that way you're not going to get more edema or more trauma. And it's also much easier to use when the guard is relatively thin. But some of the osteotomes have got very, very wide guards, and they're more difficult to work with, and you probably do get a little bit more soft tissue trauma with it. But in the long run, does it make a huge amount of difference? Probably not. I don't think so. But when I choose osteotomes, there's one specific osteotome I like from a company which has a very, very thin guard to it. So you can still feel the guard, but it's causing very little trauma.
Yes. So there is now the different type of the osteotomy also. So when you deal with the medial most part of the nasal bone, that is the medial osteotomy. When you deal with the lateral most part, that is the lateral osteotomy. And when we deal with the mid part from the top to bottom, that is the intermediate osteotomy. Okay. And one is when you deal with this part, that is the transverse or root osteotomy. So these are the different osteotomy we use. Indication, if you discuss regarding the indication of these osteotomy, regarding the medial or lateral, indication is the same. When you want to a straight deviated dorsum, when you want to a narrowing of a over wide bony vault, or sometimes when you have a just when you have a widening of a pinching bony vault, okay, and for getting the desirable dorsal ascent, these are the different indication. But for the intermediate osteotomy, the indication are the different. Okay. For the intermediate osteotomy, when you use the intermediate osteotomy, then the indication is when you have a asymmetrical nasal bone, one side nasal bone that is the longer than other. Okay. and one side nasal bone is the concave and one side is the concave. So either you use the, we discuss regarding the sequence. So either you use the medial and lateral, it hardly matter in a normal case. But if you have a crooked nose, in a crooked nose, because one side is the deviated convex side and one side is the concave side, in that case the sequence is matter. Because if you use the medial, intermediate and lateral osteotomy, then first you use the intermediate osteotomy. Why? Yes, for stability. Because if you destabilize your this part, then how can you do the osteotomy in destabilized part? So first you develop the intermediate, do the intermediate osteotomy. And another important thing, when you do the intermediate osteotomy, then which side first you do, either the concave side or convex side? Concave side. Why? Because yeah, because if you, this is really, this is the common mistake do by the beginners. When you do the convex side, they start the convex side, because first if you do the osteotomy on the convex side, then this bone does not allow to come in the midline. So first you free this part from the attachment, then this bone allow to this deviated side in the midline. So always, and if you go the literature also, the concave side, convex side nasal bone, lateral nasal wall is thicker than the concave side. So the sequence, whenever you use the intermediate osteotomy, you always remember the sequence. Now we first start the medial osteotomy.
Sunil,
Sir,
just before you do the osteotomies, can I ask a favor? If you remember back to AOICon earlier this year in January, there was a quiz and there were some students on there who won the quiz, and I said to them we would be teaching them. I was meant to be teaching them today, but actually, because you're doing this, I asked them to join your meeting and to join this today. So there should be some. Hopefully, the students are on here today, and I'll teach them next week online. But if you just, before you do disrupt all of this, if you could just very quickly just summarize the anatomy as you see it, because obviously with the skin, it's a very unique way of showing the anatomy. So if you just go through the lower lateral, upper lateral, and bone very, very quickly, it'll take you 2 minutes, and it'll be very useful, I think, for these students who hopefully have joined. And to the students who have joined, I apologize, I won't teach you because Sunil's doing such a good job today. I will teach you next week. I'll wake up early next week and teach you in India from next week. And anyone who wants to join that is also very welcome. I'll share that link with Sunil. Whoever wants to learn some very basic parts of rhinoplasty, I'll teach next week as well. But while you're there, you've got a beautiful view. So maybe if you can just, from a student's point of view, just show them the anatomy, that would be great.
yes, sir. So I think we already discussed about this alar cartilage. This is the upper lateral cartilage. This is your bony ward. This is nasal bone. This is the ascending process of the maxilla. You all clear these things. Now the medial osteotomy, some book mention the name is the paramedian, some is the median. So you never bias about that, because in each osteotomy, the important thing where you engage your osteotome and the pattern, what is that? The pattern of the osteotomy, that is the important. So in median osteotomy, paramedian osteotomy, why we call the paramedian osteotomy? Because we placed it, we engage it in the parasagittal manner, just few lateral to the central area. So look that how I just engage it, and then we just feel this part is a little bit higher rather than so we feel by your index finger, and then you use that two tap technique. Mana? So we engage it initially, we engage it like this, and your pathway, that is the fed 15 to 20 degree away. Okay, like this. Yes, 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 yes. So look that throughout you can feel by your index finger where you are working. So just little bit higher the of this part of your osteotome you can. Yes, 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 it's okay. So what is the upper limit? That is the intercanthal line. Okay, so this is the one method of the paramedian osteotomy. there is another method. Sometimes in this method, what happened when you have a severe crooked nose, when this septum is also osteomized, then you have sometimes the keystone, you will disturb the keystone area when you do both sides. So there is another method of Dr. Pond that is a very good method. Then this is the transvestibular paramedian osteotomy. So in transvestibular paramedian osteotomy, you pass this your osteotome along this mucopericardium. Look that I like this, and you go and you bypass your this K area, and then you use like tap 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 tap. So you bypass this. This is the keystone area. So you bypass this keystone area, and you just go gradually forward. Okay. Tap 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 tap. So this is the transvestibular paramedian osteotomy. So you can preserve your keystone area. So this is about the medial osteotomy. Either it's depend, either use. I usually use the transvestibular paramedian osteotomy. Okay. Now after the median osteotomy, in if you use the median and the lateral, then I usually use first the medial osteotomy, then the lateral osteotomy, because intermediate osteotomy no need in each and every case. Okay. So this is the sequence. And then the lateral osteotomy. Regarding the lateral osteotomy, the two things are important. One is the approach, another is the again the pattern. So approach, either you use the external or the internal. External, that is the basically the osteotomy use, that is the external perforating manner. Another is the internal, that is the continuous manner. So for both, the pattern is important, either because this is a very again confusing high, low, high. So first you clear in your mind. I one side I do the मेरे को देना वो lateral osteotomy.
Neil, sorry to disturb you. I have another engagement, so I'll have to take leave. I hope you don't mind.
Okay, thank you, boss. Thank you for joining.
Yeah, maybe next year, if you give me a bit more notice, I can be here for longer.
Yeah, thank you, boss. Thank you.
Okay, thank you very much.
Okay.
Nice to see you, Sandeep.
Yeah,
Nice to see you, Sandeep.
Bye.
Take care. Bye-bye.
So now again, for each and every where you engage your osteotome. Okay. So first we demonstrate the internal continuous manner. For the internal continuous manner, where you engage your osteotome, you identify this is your inferior beneath. Okay. So just anterior to lateral end of the inferior beneath, you make a horizontal incision 3 mm around. Okay. Okay. Now then you make the incision, and then this is your osteotome. This is the guarding end and this is the cutting end. Okay. So just you use this nasal speculum and you engage it. The guarding end, that is the outside. Cutting end, that is the inside. You clear this one? Okay. Like you just go, and once you engage, then that should be like around 70 degree around the vertically like this, not like this initially. And look that how I hold this one. Okay. Now this one, like you scrape little bit. Okay. So you firmly engage it. Okay. And then just like you use the 2-tap technique, ask your assistant tap 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 like this, not continuously. Okay. And like just you tap 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 dire dire. Okay. And then you go gradually down. Okay. Go gradually down. Tap 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 tap. So okay. Now the pattern, how you learn the pattern, that there is a 2 word, one is the high, one is the low. High, that means towards the dorsum. Okay. Low towards the maxilla, ascending process of the maxilla. You know, initially when the osteotomy is discovered by the Jojo, then the pathway just to fracture this nasal ascending process, that is the lowermost part of the piriform aperture to the uppermost part, that is the same, that is the low, low, low. So once we use some, then the people realize, Webster realized that if we change little bit higher, then because the problem is what happened when we fracture the lowermost part of the piriform aperture, then because of the same area, the lateral most part of the upper lateral cartilage is attached. So the lateral end of the upper lateral cartilage is medialized. The patient developed the airway breathing problem. And at the same side, the head of the anterior inferior turbinate is also attached. So he suggests rather than you go low, just go little bit higher and you preserve that Webster triangle area. So we go just little bit higher, just upper end of the anterior turbinate. Okay. And then again low. And then once you, because if you go low, 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 then you, once you reach at the intercanthal line, then you enter in thick part of the nasal bone, and that part is sometimes damaged, and that have a forward and backward movement, that is the rocker deformity. So he suggests rather than go low to low, the high, low, and again once rather than you enter in thick part, you go high up. So the standard pattern is the high, low, high. Okay. But again, in the rhinoplasty, there is a different type of the deformity. Suppose sometimes you need the excessive movement of your bony pyramid, then you just go the low to low. Otherwise, the high, low, high, that is the standard pattern of the up. Now look that where we are actually working. Tap, 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 because I feel my guarding end of the osteotome. Okay. And if I open it, then just tap, tap, look that, tap, 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 tap. You can appreciate. So what I am doing, I am fracture my ascending process of maxilla, not nasal bone. So this clear in your mind concept when in lateral osteotomy, we fracture the ascending process of the maxilla, not nasal bone. And if you look on the outside, where I am usually marker dena, I am in the nasofacial groove. I am almost in the nasofacial groove. This is nasofacial groove. Okay. And where I engage this one, I engage in this part. This is the Webster triangle area. I engage because हमने इसको यूं लिया. So I engage my little bit higher. So I preserve my Webster triangle. Now then, once you come just parallel to the this face, then you change your grip. Earlier I hold like this. Now you hold like this. Okay. Then tap tap. धीरे 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 धीरे. Tap tap. 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 And one of the important things, sometimes if you gradually go tap 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 tap, and then you just change it little bit, because sometimes if you have a strong nasal bone, a strong ascending process in a young male patient, then this osteotomy is displaced. Osteotomy is displaced because if you compare the thickness of lateral nasal wall in the lower part, that is around the 2.5 mm, that is the maximum in the mid part, rather than compare in the upper and lower part, that is around the 2.35 and something. So just you like just, and you assure that you are not in the your osteotomy is not displaced. Just tap 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 tap. Yes, tap 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 tap. Stop. So now where I am almost at the intercanthal line, the line that connect this medial canthus, that is the intercanthal line. So once you reach at the level of the intercanthus line, just you go high up. Okay. So my pattern is the high, low, high. Okay. Just tap 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 tap. So look that I almost met with my this paramedian osteotomy. Okay. Now what you do on the right side, you rotate it on the clockwise like this, like this. Okay. So now this part on of lateral nasal wall is free. Okay. So This is the internal continuous manner, and we complete free the attachment of lateral nasal wall from the medially by the paramedian osteotomy and laterally by the lateral osteotomy. So this is the internal continuous lateral osteotomy. Okay. On the other hand, if you want to do the lateral osteotomy by the external methods, so in external methods, what you do first, you mark your nasofacial groove. You mark your nasal facial groove like this, the cheek and this junction between the nose. Okay, and then you make a stab incision. You make a stab incision like this. Okay, now where your stab incision, just like if you on this side, where your stab incision, this is the my nasofacial groove, so my stab incision is just on the pathway where this is our pathway. Okay, that is the same. So I just make a stab incision, and then I just, for this osteum we usually use this 2 mm Medicone instrument. Okay, so just you क्या हो गया, you pass it and then now, so in this method just we have a multiple perforation in lateral nasal wall, just like a is postage stamp manner, just like the postage stamp manner. And ideally the distance between the two perforations, that is around the 2 mm, just for make easy the grain stick fracture. And how you hold your osteotome, that is around the 70°. Okay, just make tap 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 धीरे धीरे tap tap by the same nick, you engage it and just 3 or 4 multiple perforations. Tap tap. The angle is around the 70°, because if you have the straight, then you have the chance of the damage of the your bony septum. So rather than you go just oblique manner. Yeah, angular artery is lower down. If you are the more low, then you have the chance of angular. Otherwise, there is no. Tap 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 tap. So after your multiple perforation, then you fracture it just like this one. So this is the basically the external manner. Sandeep sir, you want to add something regarding the external or internal osteotome?
No. I think you've explained it very well.
Yeah, Kavarji? Yeah.
Yeah, I think you've explained it extremely well. No problems.
Yeah, because when we engage that, when we perforate, then just go higher up or perforation of the Webster triangle. Okay, so now either is a big matter of debate, either is the internal or is the external is good. Okay, literature says when you use the external perforating, that is you preserve that your periosteal attachment, and that is a more precise, so you have the less edema later. But the disadvantage on the other hand, that you have the scar. And for the internal, the advantage, you have a consistent narrowing, but the disadvantage, you damage your periosteal attachment. But like Dr. Pond said, that in the practical life, is hardly matter. Once you do the more and more cases, then in some cases you need the external or internal both. Okay, ultimate the thing, how you are more confidential, ultimate your patient deformity, that should be correct, that is the more important. How your professor, how your boss is doing, how is your learning, that is the more important. So you never reach it like you just go in some workshop and then someone asks, then last 20 years the external is good, I am doing the external, so you never reach it. What you are more feeling. So this is regarding the lateral osteotomy. Okay, we already discussed regarding the intermediate osteotomy. In intermediate osteotomy, just we mark between on this line. Okay, we mask from this line, uh, from the outside, like this is the nasofacial groove, this is the top part of the dorsum. So we mark like this and just make a stab incision and just like the multiple perforations. So we just for need for a moment, but definitely whenever we have the certain indication, then we use osteotomy. Okay. Now, sometimes, after the intermediate osteotomy, the median osteotomy, the lateral osteotomy, in a crooked nose case, when you remove the splint, still the nose is deviated and it's too frustrating. So, what is that reason that? So, in some cases, the root of the nose is also deviated. And if the root of the nose is not correct, then still the patient have the deviation. So when your patient have a root of the nose is deviated, then you need the transfer. This is root osteotomy. So in root osteotomy, you identify the intercanthal line. Okay, you identify the intercanthal line and just you make a stab incision here and just like the external perforating manner, multiple perforation, and you just free the attachment from the root. Okay, so your root of the nose is the deviated part, that is the correct. So this is a different type of the osteotomy that usually we use for the correction of the. And now there is other methods for modification of the bony bony pyramid like the Piaggio, but you have to know the basic knowledge. Okay, you have to know regarding the osteotomy by this osteotome. Then later, once you do the more and more cases, then you can also develop your habit with the Piaggio or other methods by powered instrument, also other methods. But this is the, you have to know about the basic. So regarding the osteotomy, have you any query and any questions? Yeah. When we with this root of the nose is deviated, just for straightening the root of the nose, that is the simple, just to make a hole. And there is so many beginner might ask, then they have a they are afraid then if you do the osteotomy for the entire nose is entire nose is fall down sunken. So no, it's not happened, because the thickness of this upper part of the nasal bone, that is around the 14 mm. That is the two. This part is so thick, so this part act as a cantilever for this entire nose. So, but you do it in judicious manner, so there is not such type of the complications. Also, this is the indication when your root of the nose is deviated, then you do the transverse osteotomy. So when you in the medial and lateral, that either can use the medial or lateral first, never vice. But if you use the intermediate, then the sequence, that is the important. Okay. Intermediate and then medial and lateral osteotomy. Okay. So sir, the osteotomy part is finished. So you want to add something for beginner friends, sir? This one. Almost this is the junction between the nasal bone and the ascending process of the maxilla. We break this part. Yeah, through the junctions. Okay, through the junctions. So this is the intermediate osteotomy. This is the paramedian osteotomy. This is the lateral osteotomy. So look that we complete free this nasal bone. We have attachment on this part. Okay. This is the intercanthal line, so we break this part. Okay, so just for desirable the movement of this root of the nose. Yes, yes, we medialize like this one, like medialize. So basically or why we free this one? Because we want to straightening. So once we free this from the rest of the maxilla, from the medially, superiorly, and then we refix it, because the goal of the osteotomy, we want to reposition of this nasal bone according, but we maintain the stability. This is the most important. We maintain the stability. So we just fix in a new position. We fix in a new position. But how can you fix? When you separate it, the surrounding rest of the attachment, then we shift it in the midline. So this is the goal of your osteotomy ultimate. Yeah, that's why I'm saying now. Look that initially, if uh, I engage lateral osteotome like this, we engage it higher, because look, you know, this is the lowermost part of the piriform aperture. What is the piriform aperture? The boning opening of this nose. That is the piriform aperture. So if this is the lowermost part of the piriform aperture, so if we engage your osteotome this in lowermost part of piriform aperture, and then we go just like go. So this is the low. But if we escape this part and go little higher, this is the high, and then again like this, and once we reach at the level, then we rotate it like this high. Clear? Yeah, banana line. Yeah, banana line. Perfect. Your banana line. So this is the high, low, high. This is the standard. Because when we do the high, then we preserve this attachment. But if you osteotome dena, rather than you engage this osteotome just like low, that is low. But we make a incision here, uppermost part, just upper end of inferior beneath. Clear? So this is the high. Otherwise, it's so confusing. What is the high? What is the low regarding the osteotome? Yeah. Yeah, it comes because these lateral and paramedian, because just this is the lateral and paramedian is just like this, so already joined. So we just free this remaining part of the nasal bone from the rest of the attachment in the transverse osteotomy. Okay. Yeah. 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 Combined. We combine. If we need, then if we need. Otherwise, if your root of the nose is already straight, then there's no need to the transverse osteotomy. Or moto is solved only by joining the paramedian and the lateral osteotomy. We free this lateral nasal bone. That's why the median osteotomy, that in the fade away in the 15 to 20-degree lateral, just for meet both these osteotomy. And suppose if your pathway is rather than like this, if your paramedian is straight, then in case you need this transverse osteotomy, because we want to meet getting for the more moment. Okay. There's a spreader graft there. Yes. Yeah. Yeah, posteriorly basically, first we create this L strut. Okay. First we create the L strut, and then after creating the L strut, if this on the posterior side, if you need a perpendicular plate cartilage for the graft purpose, then you harvest it. Or if your bony part of the septum is deviated and that cause the functional problem, then you remove it. Otherwise, if your bony part is the midline, then is no need. If your patient have only the cosmetic problem, you need only the septal cartilage. There is no need. Okay. So after the bony bolt modification, next important step of our G step, that is the mid bolt modifications. Either in the mid vault, your patient maybe have the augmentations, or yeah, like the straightening. Then for the modification of this mid vault, we usually use spreader graft or other form of the that is the spreader flap. Okay. So whatever type of the graft in rhinoplasty we use, there is 3 or 4 things are the important. First, the indication or purpose of that graft, why you use. The second, ideal dimension of that graft. The third, how you fix it, how you place it. The three things are important. Whenever you use, then if you ask why you use this graft, this is the indication of this graft. Then when you ideal dimension, and then how you fix. Suppose you want to use the spreader graft. There is a certain indication of the spreader graft. When you have a deviated dorsal septum for correction of the that, and sometimes for correction of the open roof deformity, and sometimes when you have do correction of the inverted V deformity, sometimes when you have a existing internal nasal wall insufficiency, okay, and sometimes when you want to good refined dorsal aesthetic line. These are the different indication of spreader graft. Okay, indication is clear. Now ideal dimension of the spreader graft. The length of the spreader graft, that is usually 25 to 30 millimeter long, and the thickness is around the 2 mm. Okay. Now how you place it is the important thing. So how you place it, like this is the spreader graft, then you just place it like you just create a pocket. We already have the pocket, this mucopericondial pocket. Okay, so between this mucopericondial pocket, we place it like this. We place it like this on this side and on the both sides. So the one end of this spreader graft is on under surface of the distal part of your nasal bone, and then this lower part till at the level of the anterior septal angle. This is the basic. Sometimes if you need the more strong support of this anterior part of the septum or septal extension graft, whatever you, then the length of this lower part is increased till the level of the hair. This is the extended spreader graft. Okay, so you just pass this one like this. This is the nasal bone, so under surface of this, and then you pass a needle from, yeah, yeah, how you take it, uh, because yeah, we just cut it from this septal cartilage like this. Give me the block there, na? Because whenever you make the carving of your cartilage, then first you develop the sense in your mind, then what type of graft. Because once you cut it and then you think, I think the septal extension graft, I think the I love that. So first you create what graft. So because you have only this one, so first you make the you just identify the long axis of this piece. So this is the long axis of this piece. So along the long axis of this piece, just we make the incision like this, and then this is the part of that. And if you want like as a extended spreader graft, then basically according to the more length you can use it. So this is the way then you can make. And the upper end, that usually this part that we cut it obliquely like this. This is the obliquely. So it's snugly fit under surface of the nasal bone. In the rhinoplasty, there is a short things that make the results different. So this is the way. Then now, because the fixation of this spreader is little bit tricky for my beginner friend. So thickness is around the 1 mm. Ideally, the septal cartilage is a good part. Okay. Then you just hold it by this cartilage holding forceps like this, and you pass this needle from the one side to the another like this. Yeah, that, but the both side that should be same. Okay. Then now give me the ortho-PDS. In rhinoplasty, whenever you use the any fixation, usually use the 4-OPDS. Okay, so how you use the 4-OPDS, then you pass this 4-OPDS from the one side to the another side, just like You pass from the one side to the another side. Usko pakadna, Mukesh. Usko pakadna. This cartilage is a little bit brittle because this is the old cartilage. 1 month back when I do the septoplasty, then I preserve for the demonstration. So this is a little bit brittle. So like this, and then again from on this side to this side. First on the midline, then on the anteriorly, then on superiorly. So this is a type of a horizontal mattress suture. Okay. Then just whenever you use the net, use a double knot. Double knot. You always use the 3 double knot. Cut it. So first you fix from the midline and then one on the anteriorly and another on the superiorly. So first you fix the 3 structure. First you fix your 3 structure. It's a type of horizontal mattress suture, 4 OPDS suture that usually we use. Because if you fix the all 5 structure, then it's little bit difficult. But once you do the more and more cases, then definitely you can fix the all 5 structure simultaneous. So this is the easy way to fixation of the spreader graft. And the role of your assistant is also important. Definitely, Mukesh is a very good assistant. He know what the next step. So then you remove this needle and then we fix the. इसको कोई जरूरत नहीं अपने को ultimately mark करना. Then all 5 structure you pass from the. इसको पकड़ना. This is my right side of the spreader, right side of the upper lateral. Then this one, and then you pass this one. So hump resection, because now the things are destabilized. But if a patient have a cartilaginous hump, then we already excise this part by, okay, suppose you want to remove this bony part of the hump, then we have a different methods. One is, give me the rest dinner. This is the simple traditional methods. We have this medicone rasp. So then you hold this and you hold firmly the head of the patient, and you have this elbow movement like this, like Dr. Pont told that you just like this, okay? And then after the rasping, you just give a irrigation of the water. Just you have the less chance of the callus formation because the bone particles you remove. Or either you can use your ear, like we have all ENT surgeon have the drill. So you have a long burr, then definitely I show you in tomorrow next the cases. So you can use that. Just you lift up your flap and then you can use the powered burr also. Another recently we have the Piaggio also, but in the Piaggio the things are that's little bit take time uh, just for resting. So this is the simple method, but in this, because the things are destabilized, so if we rest it, the entire nose is disturbed. Suture. Pradeep Goel sir. Sir, any your comment?
No, it's an excellent demonstration of almost everything you had covered.
Thank you, sir.
Uh,
I learn
the-
all those things from you,
so-
sir.
something you want to say about Septal extension graft.
Yes, definitely. When we move after the next, because the last step we have the tip modification of the mid vault modification.
Okay,
Then we'll discuss.
You will cover in that.
Yeah,
part,
yeah, yeah.
Okay, that's great. That's great.
So now from this side to again this side, then again in the spreader septum. So this is the this way we fix this spreader graft. It's again horizontal mattress suture. Okay, so the reconstruction is important in the so many workshop and conference. So अभी लेता हूँ. So my beginner friend they ask, then sir, in each and every case, is there a need of the upper lateral and the septum? Is there need of the septum? So they ask, is there need in each and every case? That is my personal opinion. You can separate the upper lateral and the septum in each and every case, because once you separate the upper lateral septum, then it's easy for you for the degloving of your mucopericardium is easy. And if you have, most probably if you have a crooked niche 100% without separation of the upper lateral cartilage, you cannot correct your septum. But again, the important thing, suppose your patient is not crooked nose, and ideally there is no need to separate the upper lateral and the septum, but you separate upper lateral and the septum, then you reconstruct it properly. Because this is the rule, when you correct the abnormal anatomy, you never disturb the normal anatomy. But for learning, if we disturb the normal anatomy, then we have to reconstruct it again. Okay, so within like in crooked nose, it's very difficult to correct without separation of the upper lateral. Then the same, you can use one or two suture, at least three suture you need. Okay, and sometimes if you damage this K area, then you pass a needle from this side to this side, and then you come back again, you fix it. Okay, and this is the spreader graph. So why we use the spreader graph? We already discussed the indication of that. So it spread this upper lateral cartilage just to maintain the internal nasal wall. Like how? 15 number the na? This is your upper lateral. Okay, this is your upper lateral, and there is a angle between this septum and this upper lateral, that is around the 15 degree. So we just use this part of cartilage and we spread this cartilage upper part. So that's why we called spreader graft. Okay, 15 number, 11 number blade. So this is about the spreader graft. And now sometimes what happened, suppose you have a lot of cartilaginous hump. Okay, then you excise this cartilaginous hump. Obviously, when you have a axis part of this cartilage part, then you also have the axis part of the upper lateral also. Okay, so in that case, what you do, you want to narrowing of this mid vault, then you separate this perichondrium from this upper lateral, and then some part you rotate like this. Then you suture it. This is the spreader flap. The motto is the same. Sometimes you don't have any enough cartilage for the spreader graft, then you can use the spreader flap. Okay, so these usually two basically technique, spreader flap or spreader graft, usually we use for the maintain the integrity of this internal nasal wall. Okay, so now we come down for our the sixth step of golden step of the rhinoplasty, that is the tip modifications. Okay, for understanding the tip modification, really पानी डालना इसमें, थोड़ा सा सूख रहा है, specimen सूख रहा है. So for the tip modification, first you know the important, all important surgical landmark regarding the tip. Okay, so if we discuss the important surgical landmark regarding the tip is like this. So we have some important 4 subunit regarding the tip. This is the, for a normal surgeon, for a ENT surgeon, this is entire is a tip. But for the rhinoplasty surgeon, this central part, that is the tip lobule, that is on either side defined by the tip defining points. Okay, and then laterally this part is the ala. Ala have the two, this part where this connect with the cheek, this is the ala base, and this free margin is the ala margin. Okay, and another, this vertically structure, this is the columella. Okay, that divide this nostril in the two part, and another, this is the nostril. So this nostril cavity have the two important part. One in the apex of this nostril, this is a notch. What is this one? The soft triangle. And why we have the soft triangle? Because if you learn the anatomy of this dome area, then the cephalic part of this dome, that have a notch. So in this part we have the deficient cartilage part. So there is very dense approximation between the skin to skin. So if you have the minor injury in this part, then you develop the notching later. And on the floor, this posteriorly cylindrical area, that is the seal of the nose. So these are the important landmark of the tip. Okay. Now, for understanding how you modify the tip, first you learn the tip characteristics. We have 3 or 4, 5 tip characteristics. One is the volume of the tip. What is the volume of the tip? That means the size of this lateral crus. Another, that is the width of the tip. What is the width of the tip? That the distance between the two tip defining points. What is the tip defining points? Tip defining points is the junction of this medial part of the lateral crus with this dome. Where tip defining will fall? The junction between the medial part of the lateral crus and the dome part of the intermediate crus. Okay, this is the tip defining. So ideally, the distance between this tip defining point, that is the width of the tip. Okay, another is the definition of the tip. Definition, that is the angulation of this dome. Look, that this is the angulation of this dome. That is the definition of the tip, that decide. Okay, ideally the distance between the two tip defining point is the 6 to 8 in the female patient, 8 to 10 in a male patient. Now another is the projection of the tip. What is the projection? Projection is the distance by which this tip project from the face. So from this tip defining point to the alofacial junction, this nasofacial junction. Got it? So volume of the tip, yeah. So volume of the tip, width of the tip, definition of the tip, and projection of the tip, and last is the rotation of the tip. Rotation of the tip basically is the inclination of this tip from the rest of the face, like on this side or like down. So usually we measure in a nasolabial angle, that usually around the 90 to 95. That is the acute in a male patient, but little bit obtuse in a female patient. Then 95 to the 110 in a female patient. So usually patient have abnormality regarding the these tip characteristic. Okay, regarding the size, regarding the definition, regarding the width, regarding the projections. Okay, so there are 5 techniques by which 95% primary tip deformity you can correct. 95% primary tip deformity. Rest of the 5% tip, that you need the different. What 5 techniques? One, that is the columella strut. Another, that is the cephalic trimming. And then the dome creating sutures. Then the interdomal sutures. And then fifth, that is the tip refinement graft. So first we discuss these 5 techniques by which we can modify. First is the columella strut. Start there. So again, like whenever you use the any type of the graft, first is the indication. What is the indication for using the spread and this columella strut? Just for the projection, for make the good shape of the tip, and just to make the unified tip. So then after the indication, what is the ideal dimension? It is around the 20 millimeter long and 2.5 mm width and 1.5 is the thickness. That is the ideal dimension of the columella strut. And warmer part of or septal cartilage, that is the best part for this using this columella strut. Now, how you fix it? Then first you make a pocket by this scissor. First you make a pocket, just like this. Okay, you just spread it and you make a space. Okay, now after making the ideal dimension, you create a pocket and then you insert it in this pocket like this. Okay, and then you hold and they pass a needle pass karna. You pass a needle from one side to the another side. You pass a needle from the one side to the another side. Give me the needle. But again, the important thing, if you pass this needle just like this and like this is the wrong method. Because if you fix it like this, then your tip deviated. So the entry and exit of your needle, that should be on the same plane. Got it? And now how you fix? Then you give me the suture. You can use either the 4O or 5O PDS. If your street, then that is a cartilage of the rib cartilage, then you can use this 4O or otherwise 5O. So then either you can fix directly, or if you pass from this to this, the skin to skin, then the patient later feel the knot. So then you fix it subcutaneously. If your knot is subcutaneous, then later patient not feel. That is the good. So just like from this, you need needle hटाओ मुकेश. Again, this cartilage is so weak. Then on this side, like this, पकड़ो उसको नीचे से. And again from another side to this side. So what we're doing, we fix our columella strut. So this is again a type of a horizontal mattress suture. We use the 3-knot, but rather than you use, this is the wrong method to fixation of the knot. You always fix your knot along the long axis of your graft, like this. This is the right manner. So you fix it. You fix it like this. Always use the 3-knot. Cut it. So this is the columella strut. Now another you use at the base and on here. But your upper end of your strut, that should not beyond your dome area. Okay, cut it, scissor dena. So this is about the columella strut. Yeah, any questions? Note this note that comes under this flap.
Dear
Yes,
Sunil, could you please show the returning point? I forgot the name of the of the lateral crus of lower lateral cartilage. The point where reflecting from the descending limb to the intermediate crura.
What you asking?
The point where meeting of the limb of lateral crura, descending limb, and the intermediate part, the point between them.
Yeah, basically this is a part that is the tip defining part. That is the transition zone. This one. You ask this one. This is the attachment of this intermediate part, the dome part. So lateral end of the dome part and the medial most pass of the this lateral crust, that is the tip defining point, dome junction line. Mark dena, dena. And the lateral most part of this lateral crust that attached with the accessory cartilage, small accessory cartilage. So this is the use of the columella strut. Okay. Now the next, that is the cephalic trimming. Okay. So it's a subcutaneous. Basically, it's the subcutaneous. When we cover it under the flap, that, and when we do this columella state in a living patient, then the things are that they have some strength. That the things are each and everything is opened. So otherwise that exact come under the flap. Okay. Now the cephalic trimming. So again, the indication of the cephalic trimming, when you want to reduce your volume of the tip. Okay. Then we excise, because this is the cephalic part of the lateral crus. This is the caudal part of the lateral crus. Okay. Now, how much you excise? It's again the question, how much we excise. But how much we excise, that is not important. How much we preserve it, that is the important. You know, because the old literature that mention the 6 to 8, because in rhinoplasty all mostly literature are the Western database. They have the thin skin patient. The 6 to 8 is enough. But in our scenario, we have the tough thick skin. So around the not less than 10 mm. Marker देना. Not less than 10 mm. वो देना measure करने का. So you can measure it. Look that. You can measure it. Look that. If we measure it, that is around more than 10. More than 10. Okay. That is around the 13. So we just preserve 10 and rest. Just like, how can we just like, we just mark it, and we can use like, if we want to the preserve the 10, then just like we mark it like this point. So the rest of this part we can remove. Yeah, well, yeah, for my male patient, basically at least not less than 10. In female patient, it's okay, little bit. So then how much we remove it? Mark 15 number blade. So then we make a step, we cut. और पकड़ना इसको यहाँ से, या आगे से पकड़ो यहाँ से. So we make a step cut. And now just you pass a scissor. You can use for infiltration in the vestibular skin for my beginner friends, because for easy to the dissection. Okay, I usually use this needle, this scissor, sharp scissor. But for beginner friends, if you feel the problem, then we can excise this in this way. So this, we just excise the cephalic part of this lateral crus. Now again, so many friends, they think when we excise this, then we damage the scroll area. So you clear from your mind, then look that we not damage this scroll area. This is the scroll area. Okay. So you clear, yeah, because scroll area is around 15 mm overlapping between the distal part of the upper lateral cartilage and superior. And it's basically a ligament structure. So we need not damage the scroll area. And in the last, what you can do then, you make a suture again of this structure. So the reconstruction of the scroll area 50, then so we not damage, because sometimes when we see in the conference or workshop, we think we damage the scroll area. So we just make a suture it again, just like this is my scroll area. So we make a suture and we reconstruct it like this. Okay, clear. But it depends how much you remove. Only the cartilage, only the cartilage. Though in cephalic trimming, we reduce the volume of the lateral crust just to make the more malleable of this. Look that now again the same things are. So just to make more malleable this lateral crust. But the most important thing, just to prevent the alar retraction, at least you should preserve the 8 to 10 millimeter this lateral crust. Okay. So this is the second technique after the columella stud, then the cephalic trimming, then the tip sutures. So usually we need the sutures just for getting the more definition, that is the intradermal suture. So how you place the intradermal suture? Pani dalna. From the intradermal suture, you pass this from medial to the lateral like this. From medial to the lateral, hold this one, isko pakdo. And then again go from the lateral to the medial. Then again go from the lateral to the medial. And then the node that should be on the medial side. So look that now the change the definition. So this is the dome creating suture. This is the dome creating suture. Cut it. Okay. So for getting the more definition of the nose, but the node that should be on the medially. Sir, Dr. Sandeep on. Sir, है क्या? Join कर रखा है sir? Yeah, cranial tip suture, that is the different, just like a basically dome creating sutures. There is a new concept. In new concept, just they want this part of this cephalic part of this lateral crust, just like they want like this one. So the suture, that is just type of this dome creating suture, but the way like this, just little bit posterior to this one, and like this in the oblique manner, uh, like this. They just yes, posteriorly, but the oblique just near the entry of and suture, just to evert this part. Look that, just to evert this part, just to evert in little bit cranial portion of your this dome area. So they are the cranial tip sutures. We discussed this in advanced step on the tip now. Cut it. So this is the cranial tip sutures and dome creating sutures. Okay. And then the sutures, they connect the both dome, that is the interdomal suture. That is the interdomal suture. So in interdermal suture, we reduce the width of the tip. Okay. Again, from this side to the another side. But they all the safety that should be maintained, है ना? Then again the double node, that is not too tight. If you make this too tight, then you create a pointed tip. If you have the too loose, then you have the widening or wide tip. Okay, so you never bias or confuse between the intradermal suture and the interdermal suture. Just like intercity express the connect the two cities, so interdermal suture they connect the two dome. This is the interdermal suture. Intradermal, that in the same, just to create the more definitions. Okay, cut it. uh it's not compulsory, in rhinoplasty there is no standard rhinoplasty. Not in each and every case you use the intradermal or interdermal suture. We just discuss a certain a pattern. Sometimes if your patient have a good definitions, then is no need to the dome creating sutures. So just this clear in your mind that not in each and every patient you have to use this intradermal suture, and what the patient need, what the patient need. Okay, yeah, sometimes sometimes there is no need to the intradermal sutures, you just make the interdermal. But usually we follow this sequence, then we need the intradermal and the interdermal sutures. See, knife na. So so these are the like technique like the columella studs, cephalic trimming, dome creating suture, intradermal suture, and we use one more technique, that is the tip refinement graft. Just use of the tip refinement grafts. Basically, just need more refinement of the tip. Okay, so there is a different like the cap graft, like the sealed graft, like the umbrella graft, but most commonly we use the sealed graft. Sealed graft, we use the sealed graft. ये देना ये. This small graft, just like in a sealed shape manner. Again, like the indication, like the ideal dimension, and either the fixation, whatever a graft you use. Indication of the sealed graft, when you have a thick skin patient, when you have a refinement of this your infratip lobule part, when you have a axis part of the infratip lobule, and suppose you want to need little bit more projections in a revision case or a thick skin patient, then this you use this sealed shape graft. But needle dena, how you fix it? Because you fix it at the just anterior to this part, you pass in a needle, and then you just fix it with this in this way. And this part, this little bit part, this beyond the dome area, this part is beyond the dome area, and ideally the distance, this is the shoulder of the, this is the shoulder part of the shield graft, that ideally at least 6 millimeter that should be. And we put a one suture here, one suture here, one suture here, one suture here, and this part gives support to the dome or soft tissue envelope. But sometimes what happened, this part, this part, axis part beyond the dome part, that is the bend due to the thick skin pressure. So what you do, that the small piece of the cartilage you use just on posterior to this one. Okay, so this is the use of the spreader graft. Clear? Now, these are the 5 techniques that commonly we use basically for the primary tip cases. 95% cases you can do by this technique. Now, how can you do the rest of the 5%? For the rest of the 5%, for this central limb of the Anderson, you have some different techniques like the septal extension graft, like the septal replacement graft, like the tongue in groove, like the modified tongue in groove, like the modified tongue in groove setbacks for modification of this central limb of the Anderson. Okay, and you need the certain techniques for modification of lateral limb of this Anderson tripod. Procedure देना 15 number blade. So first we just open it and for my beginner friends, I think you develop first the 95% cases is good for you. If you attempt the 95 cases, you left the 5% cases. So you build up your confidence. So now, first that usually use the septal extension graft. Okay. Now again, there is a confusion in the mind. Then why use the septal extension graft? You use the columella strut. Okay. So you clear from your mind the use of columella strut for a limited projection. You know, but septal extension graft is a really a structural graft. When you need the significant projection, when you need the good foundation of the central limb, okay, then you use the, when you need the rotation also, either the upward or the downside. So this is the septal extension graft. Then again, after the indication, then again the dimension. That this is the use of the repetition, you know, effect aane lag gaya. So the dimension, that is the 20 millimeter long and the 25 millimeter is the height of this ideally. Okay, then how we place it? Then just you fix it like this. Okay, and how you fix is really so important. Septal extension graft, it is really a so versatile graft. Sometimes you get some unwanted effect and that create the patient lot of problem. How? If you fix this spreader graft like this, then the nose is over rotate. Okay, you got my point? And if you fix it like this, then you have a droopy tip, because these are the unwanted effect. So when you fix your spreader graft, then there is a different method. Either you end to end, either you fix from the this to this. This is the end to end, but this is the difficult. So end to side, that is the easy methods. Got my point? Now you just check not beyond the margin of this medial crus. Okay, just like not beyond the margin of the lateral crus, and then just like वो लगा ना यहाँ पे, you pass a needle, first you check like you are okay. Okay, but not too much behind, because if you fix it just like this, then you have a groove again, you create the problem. Then you need again the one part of the strut more, and you don't have any cartilage now, so it creates the problem. So you just behind this limb of skin of the inverted V, and then just like, and then that should be straight, that should be exact or straight, not like this and not like this. Okay, then you put it, then you pass a needle. This is the end to side manner. Then you pass a needle. Give me the Mukesh needle pass karna. Pass the needle. You pass the needle. Now give me the 4 OPDS. 4 OPDS. Four OPDS. So then again, दूसरा दोना यार ये क्या है? So just you pass from the one side horizontal mattress suture from this side to this side, and again on this side to this side. छोटा है suture, ठीक है. So we fix it. Hold करना. When you have the small suture, then you have the problem. ये दिखाओ मेरे को. So we fix it. Yes, good. Again, along the long axis of your graft. Okay, just like this. Use the double knot always. Whenever you fix your any graft, then you use the 3 knot, cut it. Suppose if you want like the good more support, then your spreader graft, the length of the spreader graft till at the level of like this. That is the extended spreader graft. When you are doing a surgery of a Bender syndromes and you under projected tip, thick skin patient, and you need a strong foundations, then you can use this extended spreader graft. You can use. Okay. So then one more suture. So first on the mid and then at the bottom, because the fixation is important. इसको पीछे बांध देना, टाई कर देना. So from this side to this side. First we suture with the septum. Double knot, cut it. Now this part also that should sutures, because otherwise this should be free. Okay, so just you pass from this to this. Dr. Hakim is there. वो लेंगे, अभी लेंगे.
I am back, Sunil.
Yeah, boss.
Uh,
So we just discuss about the tip part. We already discussed about the columella struts, cephalic trimming, dome creating sutures, cranial tip sutures, and interdomal sutures for primary cases. But we just discussed some advanced deformities. So for how you modify the central limb of this tripod. So I just demonstrate about this septal extension graft. So I just fixed this septal extension graft in the end to side manner. So really, I just explained to my participant that septal extension graft is a very versatile graft. If you are not fixed in the right manner, then sometimes you develop the unwanted effect like the over rotation or under rotation or something. So this is the use of the septal extension graft when you need the strong foundations, when you need the strong projections, significant projections. Okay, then how you fix. Now, another technique for the modification, some an advanced tip, that is the tongue in groove. What is tongue in groove? There is two word, tongue. Tongue, that means this medial crust. Groove, that means the space between the medial crust. Suppose your this part is axis, you have a axis columella shoe. Suppose you have this axis part, you have the axis infratibular part. Then how you deal with, how you correct it? We want to reduce the columella shoe because there is good aesthetic pleasing nose. Ideally, we have the 2 to 4 mm columella shoe. The distance between the ala margin, and ideally there is a gull in wing flight appearance. Okay, so when you have a more than this, then we want to reduce. How you reduce it? Then this both medial crust, we advancement on the rest of native septum. Okay, then when we advancement of this medial crust, then we rest of the present native septum, we pass a needle from this to this, and we suture this medial crust on caudal part of the septum, that we call the tongue in groove. Okay, but sometimes what happened, then your distal part of the septum is weak, and then first we reconstruct, like in this case, you give me needle, then you advancement on that part of this medial crust, that is called the modified tongue in groove. You got my point? If we fix this medial crust on this septum, if we don't have this one, then on native septum of the patient, that is the modified tongue in groove. But suppose first we reconstruct this caudal part by the septal extension graft, and we just advancement of this medial crust, bada double prong retractor. We advancement like this, like in this patient, look that this is medial crust, this is medial crust. Suppose like we suture this, needle pass karna upar aur niche mein case. So this is the modified tongue in groove. So you got the difference between the tongue in groove and the modified tongue in groove. That means in tongue in groove, you fix your medial crust on the native septum. But on modified tongue in groove, you fix your medial crust on the septal extension graft. Now, how you fix it? Again, suture dena. Then ideally you can pass needle from this to this, but there is a very good methods. Kapil boss, this is your technique. Then how you fix your septal? Basically, you note that is the midline rather than on the skin or outside. So I learned this from your technique. Then you pass again from this to this, and then on this side.
This I do, and I also learned from the other people, not my native technique.
But this is good because
Yeah,
you note that is inside.
yes.
But the important thing, the entry and exit of your needle, that should be same plane. So look that your note, that is the inside. Okay, you note that is the inside. Otherwise, sometimes if you go the skin to skin, then your patient feel that note. Cut it. So the same, you can use the one more sutures at the bottom and one on the mid. At least you need the 3 sutures. So you just clear the tongue in groove and then is modified tongue in groove. So the both technique used for significant for projections. But sometimes if your patient have a over projected nose, and if you want the deep project the nose, because the mostly patient need the projection, but sometimes if a patient come and then ask you, I want my deep project my nose, so then in that situations you just free this medial crust from this skin, and then you section it. Suppose this is medial crust, you free, you section cut it, and you overlap like this, suture it, and then that part, if you fix on this septum, that is the tongue in groove setback technique. Okay, that is the tongue in groove set. Yeah, you already clear about this tongue in groove modifier? Suppose this is your medial crust. This is my medial crust. Okay, this medial crust is too long. Okay, so we free from this skin, we make a incision, and then we overlap, we shorten it, we deproject, and then we suture on the rest of septum, just like tongue in groove. That is the tongue in groove setback for deprojection of your nose. Tongue in groove setback. Okay, so these are the different technique for the modification of the central limb of the Anderson. Okay, and sometimes if your anterior part of the septum, like in the post septoplasty cases, or like in the binder cases, if your caudal part is too much deficient, then rather than septal extension graft, you use the septal replacement graft. So in that case, what you do, because in the post septoplasty cases, every surgeon left little bit dorsal part of the strip. Okay, so you use a fan sept graft, like give me the marker. In that case, you use a fan sept graft, just like a like in this is a fan sept graft, like this. So this part of the graft that you suture with the dorsal part of the residual part of the septum, and this part use as a septal extension graft, and just you make another strip of cartilage with the suture, so you can correct it. Okay, that the septal basically replacement graft. So these are the some advanced technique for modification of the central limb of Anderson. Now you come on the lateral limb of this Anderson. Okay, so mostly in this lateral part of the Anderson, the patient uh, uh, basically have the problem regarding this lateral crust. This lateral crust have 2 or 3 or 4 common problem, common deformity. What? Regarding the size, maybe it oversized. Okay, second, maybe regarding the shape, because ideally shape of this lateral crust is the convex. Maybe he have like this. Okay, what is the name of that? That is the paradoxically lateral crura deformity. Okay, so either this lateral crust have the problem regarding the size, regarding the shape, or sometimes one another type of the problem, that is orientation problem. Ideally, the orientation of this lateral crust distal end is towards the lateral canthus. Look that. But rather than sometimes towards the lateral canthus, if on the medial canthus, that is the cephalic malposition of the lateral crust. Okay, so regarding the size, regarding the shape, regarding the orientation, and sometimes regarding the strength, sometimes it's so weak, so flimsy. So these 4 problem usually have this lateral crust. If the patient have a over wide lateral crust, you already know how you correct it. How you correct it? By the, when a patient have a big this one, then how we correct it? Cephalic trimming. Cephalic trimming. This is the first day. This is the cephalic trimming. Now the second, that is the, if maybe a patient have regarding the sap, that is maybe if the patient have एक वो और देना मेरे को, if the patient have like this, मेरे को देना, आपके पास वो पोस्टर है ना जो मैंने दिए थे, this one more, this one more, ये नहीं है आपके पास, वो नहीं है आपके पास. So maybe if the sap is like this, then this is the paradoxically lateral crura deformity. How we correct it? Scissor देना. paradoxically lateral crura deformity. So how we correct it? Then first we release, because it's very difficult in this, but we just try. Yes, we just sprayed it. We can use the infiltration also. So we just free, we just free, we just free. Because infiltration is good when you use the infiltration. If you have a buttonhole in this vestibular skin, then you never leave it, you just repair that. Okay. Then again you fix, separate it laterally, because we put the suture for the scroll reconstruction, so I just leave it. So counter traction is, look that if that man hold this one, that is easy for me. So counter traction is always important when you open the nose is also. So first you fix, separate it. Okay. Now if your patient have a deform, basically diffuse concavity, like entire this like this, then you cut it and then you flip it like this. That is the lateral crura flip. You got my point? If your lateral crus have the diffuse concavity, then you separate it from here and 360-degree you flip it. That is the lateral crura flip for correction of the paradoxically lateral crura deformity correction. Got my point? Yeah, we cut it. We cut it like, look that. Just I cut it like this. Okay. And then I rotate it and again fix it. That is the paradoxically lateral crura deformity correction, lateral crura flip technique. Okay. So regarding the size by the cephalic trimming, regarding the sap by the lateral crura flip, but sometimes what happened, the some patient they don't have the diffuse lateral crura sap deformity, they have some partially. Suppose the small part of this one have the concavity. So when a patient have a partially paradoxically lateral crura deformity, then there is no need to flip the entire lateral crus. Just you make a simple pocket and you put the small graft under surface. That is the lateral crura underlay graft. Support के लिए small graft. Because unnecessary, when you correct the abnormal anatomy, you never disturb the normal anatomy. This is the important rule. Okay. So you judge that your patient that have a partially or have a diffuse paradoxically lateral crura deformity. Okay. Now after the size shape, the next deformity of this lateral crus is the orientation. For orientation, look that what orientation? Look that this picture of the patient I show you. This is the lateral crus. अरे उनको audiovisual वालों को बुलाना. This is the lateral crus. This is lateral crus. Look, this is the ideal. This is the ideal orientation towards the lateral canthus. But sometimes the things are changed. When this orientation is towards the medial canthus, then the patient develop like this, like this. This is the cephalic malposition of the lateral crus. Ideally, the angle of lateral crus is more than 35, around the 45 degree, okay. If less than 35 degree, then the patient develop the cephalic. Then what happened? Because when the patient have the cephalic malposition, then the patient lost the support of this alar rim, because this part gives support to the anterior part of the alar rim. So the patient develop a deformity that we call the parenthesis deformity. Okay, that we call the parenthesis deformity. parenthesis deformity. So in parenthesis deformity, just there is a bulging in, and the patient develops some external nasal wall insufficiency also. ये बताना एक बार, ठीक है ना? So this is the basically the cephalic malposition of the lateral crus and the parenthesis deformity. Look that this, you understand this one, because this is the around the almost the 45-degree angle, okay, and this is the around the less than 45 angle. So the patient develop this deformity, okay. Now how you correct it? Now, so for correction of this one, look that we want to reposition in new position, new orientation. So when we correct something in the new position, then we need the some graft, okay, for fixation of the छोटा मेरे को ग्राफ्ट देना, छोटे ये दे दे, कोई दिक्कत नहीं, सीजर देना. So for fixation in the new position, like we need a graft for fixation of this structure in new position. Now, how can we use the graft? Either we graft use the in this way, or either the in this way. Okay. If this graft you fix like in this way, then this is the lateral crura stud graft. That means if you fix your graft on under surface of the needle pass करना, नहीं पकड़ के, ऐसे नहीं पकड़ के, थक थोड़ी गया तू, पकड़ के पास करो, हाँ ढंग से. If you fix your graft on under surface of the distal part of the lateral crus, because I cut it, so this is the free, so this is the lateral crura stud graft, okay. If I put it on under surface of the distal end of the lateral crus, that is the Alar batten graft. I personally feel that between the lateral crura stud and Alar batten graft, this lateral crura stud graft is better, because this end of the cartilage that have the pushing effect on upside. But if I use this on upside, then have the push on the downside. So the tension effect of this part, that is the good for the patient. So this is the lateral crura stud graft for the orientation deformity of the lateral crus. Okay. So we fix it by the graft, by the suture, 2 or 3 suture, and this part where we fix it, this part we fix it on outside of the piriform aperture, just on the piriform aperture, just to make a सीजर देना, इसको एक सूचर लगा दो एक बार, because this part we separate, so this is the unstable. इसको पकड़ो ऐसे, just we create the space here on this side in the new orientation. Look that my direction of the seizure is towards the lateral canthus, okay, towards the lateral canthus. So just on outside of the piriform, not inside. This is the important thing, outside of the piriform aperture. So this part we put inside of this, just like this, and we suture it. So we just put in the new orientations. So this is the lateral crura stud graft. Okay, you clear? Now sometimes when patient have problem regarding the regarding the strength of this, when you have a weak lateral crus, then there is a 2 technique by you correct the weak lateral crus. One is just like 15 number blade there, 15 number blade. One is just you make a incision, one is just you make a incision, just like you make a incision, okay, just okay, पकड़ना, just you make a incision, you separate it, and then you just make a pocket on this under surface and move on underside. That is the lateral crura turnover. You understand? That means we just create like this, Yeah, and इधर से भी इसको separate किया. So just like this one, we separate scissor देना. We not complete separate, just make incision and then rotate it on under surface of this one. So we just turn over after create a pocket on this rest of the cartilage on this. So we just like fold it. So this is the lateral turnover. So these are the basically deformities regarding the lateral crus or lateral limb of the Anderson. Sometimes the patient some have regarding the SEP, usually we use some words like my patient have the broad tip and the bulbous tip and the boxy tip. So this is also clear in your mind. Then if your patient have a distance more than as usual like the 6 to 8 or 8 to 10, that is a broad tip. Okay, if the patient have a distance, that is the broad tip. Okay, and what is the boxy tip? Then look at this dome, they have a angle between like this. If ideally the angle of the dome divergence is the 30°. If you have the more than this, then you have a boxy tip. You got my point? If you have an angle of dome divergence that is the more than 30°, then you have a boxy tip. And what is the bulbous tip? Bulbous tip is basically when you have an index more than 0.6 between the tip width oblique the ala base width. The distance between this tip width and this ala base width, the ratio is more than 0.6, that is the bulbous tip. Give me the dinwa, wo apne paas hoga ek. Yeah, look that. This is the normal tip. Okay, the angle of dome divergence, उनको बुलाना दीपक जी को. Angle of dome divergence. This is the dome and ideally the 30° angle. Okay, this is the 30° angle. Look that when a patient have more than this is the boxy tip. So when we use in the routine practice, then we know what exactly meaning of this one. What is the boxy tip? What is the bulbous tip? And look that this is the bulbous tip. So in the bulbous tip, the ratio between this one and ratio between this one is more than 0.6. Then we use the bulbous tip. This is the boxy tip, and this is the bulbous tip. Okay, so this is almost all about like our all steps, and like the first we discuss about the infiltration, and then the exposure, and then the septal modification, then the bony pyramid modification by the different combo of the osteotomy, then mid vault modifications by the spreader graft and the spreader flaps, and then by the tip modifications, and then last is the closing. I usually use for the closing the 5 tip suture techniques, but in this patient, because now we separate the skin, it's very difficult to demonstrate. Tomorrow when we go on the live session, then we discuss. A last basically deformity that is very rare, but it's very confusing regarding the Alabas modifications. So Alabas modifications, we just discussed the brief about the Alabas modification is also like the, but what you asking something? Lateral crura steel. Yeah, lateral crura steel is what is that? Then suppose this is your lateral crus. Okay, this is your dome. Okay, so we separate this part and we create a new dome, just like we separate this lateral crus from the underlying the vestibular skin, and then we create a new dome. We just steal some part of the lateral crus just for getting more definition. This is one of a method for the projections, lateral crura steel, that in a cleft lip nose cases usually we need lateral crura steel. Okay, when in the live case usually I demonstrate. So this is the lateral crura steel. regarding the basically the Alar base excision, uh, usually we try to avoid the Alar base excision. There is a two reason why we avoid the Alar base excision. One is the scar concern for the patient, and the second is the lack of the anatomy, lack of the confidence, because we also afraid about the. So there is a rule: if you bias, if you confuse regarding the Alar base surgery, you don't do it, because sometimes regarding the your patient asks to you, I need the Alar base excision, and your patient tip have the under projected tip, and after the projections, the automatically the Alar flaring or something. So you have to know the comprehensive knowledge regarding the pre and the post. Okay, then you explain to the patient, because if you once you excise, then it's very difficult to reconstruct. Okay, so you also know the morphology regarding this Alar uh, lobule, then your patient need the either the Alar base excision or Alar seal excision. So look that if the distance between these Alar facial junction, okay, the distance between the Alar facial junction is equal to the intercanthal distance. This is a rule. Okay, inter-Alar width, that is the equal to the intercanthal distance. Okay, if you have the more than, because this is the Alar margin, this is the Alar base. Okay, if you have the excessive concavity of this part, that we call the Alar flaring, that we have the Alar flaring. Okay, and if you have the excessive width of this one nostril, between the nostril, that you have the excessive inter-Alar width. Okay, so if your patient basically have this normal inter-Alar width, first you know that if you want to correct this Alar flaring, then you excise this Alar base part. Okay, but if you want to reduce this width, then you excise this seal part, nasal seal part. Okay, so first you decide that what is your patient have a excessive Alar flaring, or if your patient have a excessive Alar width. Okay, if your patient have this excessive Alar concavity flaring, then you reduce, you excise this some base part of this Alar base excision. How much you excise, that is important thing. How you decide, you measure between the inter-Alar width, and then basically you just mark a line from this medial canthus, and how much amount you have the flaring, then we just excise the incremental manner. So in the if you have patient, then we just demonstrate. So it's important, then your patient have a excessive Alar flaring or excessive Alar width. Okay, so I think this is all about regarding all steps of the rhinoplasty. And if you have the any more query regarding this, then definitely you, after the first you just finish your lunch, and then we just, you can feel the nose, and then we discuss more. I think this is all about, because more than this, nothing.
Yeah, Dr. Sunil, I made a few things.
Sir, huh?
Just show them the Alar reduction process.
So you want to show that Alar reduction, because Dr. Kapil have a very good technique of the Alar reduction technique. So basically, just I show you the simple procedure for Alar base reduction. Suppose if your patient, the marker dena. Boss, I want to learn your technique from you. You have a different technique, but I show you for my participants the simple technique for Alar base excision. Basically, suppose if you want to, if you have a excessive Alar flaring, okay, then if you want to this excise this Alar base, then first you mark. So your marking, that I usually mark just few millimeter above the this Alar facial junctions. I think Dr. Kapil not agree with this one. They use the lower marking on this Alar facial groove, but I usually just mark just little bit out, few above this elafacial junction. Okay, and then the upper, just you according to your need, you mark on the right side just around the 8 o'clock, on the left side lateral extension around the 4 o'clock, and then you just make an incision till the at the just subcutaneous tissues, and we excise it, and then just you use as a template. If the patient, I mean, both sides, then you just mark on this side, and then we excise. Dr. Kapil Boss, you want to add something, because your technique is very good. Something.
That is slightly different from this.
Yeah,
It's
that
okay.
is slightly
No problem.
different. So this is basically ELA base. But suppose if you want, if you have this excessive seal, this posterior cylindric alias seal, then you want the wedge excision of this part. So just you mark like this, and then you mark like this, because this is the free skin. Then you excise this part. Just you reduce this inter-alar width. Just you reduce this part, we excise this part, and then we narrow the nasal cavity, reduce the inter-alar width. Skin and subcutaneous, ideally till the mid muscle level. Boss, what is exact the depth of ala base excision?
Only skin from outside, nothing else.
Only skin.
Yes.
Yes.
So in that way, you are not actually cutting the blood supply, as well as you are not releasing the forces which are responsible for the convexity of the ala.
Yes, perfect.
And you are not going inside the nasal floor.
Yes.
The excision is restricted up to the sill only.
Yes.
Yes.
So I these are the some techniques, and just the 7G steps, 7 golden steps. So in the next 6 days, we repeat all these. So repetition is the key of our course. We again repeat the same thing. So, and there is a lot of techniques, but you just first learn the basic techniques, primary cases, simple cases. So you build up your confidence. So I think we just wind up, boss, and thank you for the joining. Give your precious time. I think Sandeep Pon, sir.
I'm here. I'm here.
Oh, sir, great.
Sorry, I was stepping in and out. I'm also I've got one eye also on the cricket, as you know, India are playing today.
Sir, so we just I try to just all basic techniques for my participants, and
No, you've done a fantastic job, and you know it's as I always say to you, it's wonderful seeing how much you've learned, hopefully over the years with me being there with you, but you are now doing the steps in pretty much exactly the same way as I do, and it's great to watch. So congratulations. I'm sure the participants will have a wonderful few days with you in Jaipur, and hopefully we'll be meeting in Calcutta soon as well, in about a month's time. I'm looking forward to that as well. So my best wishes to everyone who's there. Pradeep, I don't know if Pradeep is still there. It'll be good to see you again soon, and same with you, Kapil. It's been a long time. Let's try and catch up soon.
Yes.
Dr. Kapil,
very good job, Dr. Sunil.
Thank you.
You explained everything in the fine detail, actually.
Thank you.
Even the person who is very new to the rhinoplasty can learn everything today. Could have learned.
Yeah.
And I'm sure that participants, as well as all delegates who are on screen right now, they might have learned the nuances of.
Your face looking quite glowing. What's the reason?
I don't
know.
Yeah.
Me, I don't know. Maybe it's because India just got a second wicket.
Or drinking a lot of wine.
No wine. I'm just it's early morning here. It's too early for any wine.
Nice to see you after a long time. Thank you.
Yeah, absolutely. No, I'm just it's early morning. We're watching the cricket as well as watching Sunil operate. So it's great. Sunil, your headlight even makes you look like me now.
Yeah, yeah, yeah. I bought this one, sir. Yeah, because
I know you
phone
did.
needs some magnification, so this one is good. This one is good.
Yes, yeah. It shows you're getting a little older now, which is good. Okay, well, send my regards to Sushila. Send my regards to Mukesh.
Yeah,
He did a
today,
great job.
yeah, she's in the Delhi for some surgical demonstrations. Evening, she will come.
Yeah.
So,
Sure. Okay,
so
well,
I definitely
pass
see.
my regards to the staff, and Mukesh, you did a great job in assisting you as well.
Yeah, thank you, sir. Thank you. And again,
Okay,
okay, sir. Soon we'll meet in the Kolkata next month.
absolutely. We'll meet in Kolkata. Yeah. All right. Take care.
Okay.
Bye.
Bye, Sunil. Bye.
Thank you, Kapil Boss.
Yeah,
Thank you,
boss.
Dr. Hakim.
Thank you so much. It was really nice.